Hello, everyone. So this is the last installment, part 4 of the respiratory system for biology 233, summer 2018. So in the last slide that we covered at the end of the last screencast, there was basically a verbal description of what you see before you. So we're talking about oxygen loading into a red blood cell at the alveolar capillary interface, and unloading of carbon dioxide and how those two things are related, because they are chemically, as you learned in lecture. So I'm going to pick an intermediate blue here and just run you through this, and then we will move right along. So as we go through this, just be mindful of the key, just to keep track of all of these abbreviations. So it's too hard to fit all of these words into the space of a single red blood cell, so they've been abbreviated. Okay, so remember we have partial pressure differences driving these arrows in their respective directions, and then the relative sizes of the arrows indicate the steepness of the gradient. So this gradient is very steep, and this one less steep. The arrow size also indicates the relative percentages of each gas or gas carrying method. So 98.5% of inhaled oxygen ends up on hemoglobin, as opposed to only about 1.5% directly dissolving into the plasma. So let's start with this arrow. So due to the steep partial pressure gradient between alveolar air and deoxygenated blood, oxygen is going to move from the air into the blood. Now, it's going to encounter hemoglobin, specifically deoxyhemoglobin, which has a proton bound to it instead. So, loading of oxygen is going to decrease the binding affinity of hemoglobin for protons, causing the proton to dissociate, and then we get oxygen being loaded onto hemoglobin. So, what happens to this proton? Well, the proton stays, and remember, these are units of acidity, so we don't want these to build up inside of a red blood cell, or certainly not in the plasma, so it actually ends up coming up here and participating in this reaction, which is your blood buffer system. So the chloride shift moves a bicarbonate into the red blood cell, but you don't want a net gain of anions. You have to lose an anion as well, so that's exchanged for a chloride so that you get a net change of 0 anions. So you don't have a functional charge change due to the constant influx of bicarbonate. So these two things combine with each other to form carbonic acid. And then carbonic anhydrase, which is, I'm going to put an asterisk by it, it's very important. Carbonic anhydrase is going to catalyze a reaction wherein carbonic acid is decomposed into carbon dioxide and water. And I notice here that carbonic acid is not actually defined in our key, so I'll just write it right up here. There it is. Okay, so that results in a steep gradient between your body and the environment, where there's a lot of CO2 in here and not very much in the alveolar air, and same deal with water. So you end up breathing out carbon dioxide in the amount of about 70% from this reaction, and also water vapor. So this is why you constantly are losing water just by breathing, so stay hydrated, folks. Hemoglobin can also carry carbon dioxide because it binds to the surface of the protein at a different moiety than does oxygen. So they can carry both at the same time, actually. So this is going to dissociate into hemoglobin and CO2, and about 23% leaves that way, and that includes carbamino compounds, which are CO2 plus plasma proteins. So I'm going to put up here IE, albumins, etc. So basically, amino acids have charged side chains, and CO2 can bind to portions of those, just the same way as it binds to charged side chains on the hemoglobin molecule. And then the remaining 7% leaves from the dissolved gas. So internal respiration is the exchange of gases between blood and tissue. So this is basically everything you just saw with external respiration, but the opposite direction for the arrows. This results in the conversion of oxygenated blood into deoxygenated blood, and the diffusion of oxygen proceeds from the blood into the respiring and active tissues. So at rest, only about 25% of available O2 enters cells, leaving you with that venous reserve, where there's leftover oxygen in your quote-unquote deoxygenated blood. So during exercise, of course, though, your tissues are working harder and respiring more quickly, and they're demanding more oxygen, so more of that oxygen is going to leave the blood and enter the tissues. Same time, a respiring tissue is going to be pumping out more CO2, and that's going to create a steeper gradient between the tissue fluid and the blood, so that's going to drive CO2 into the blood. Okay, so again, we have a word slide talking you through systemic gas exchange, and then we're going to look at the picture as well. So we have carbonic anhydrase again. It's kind of our star of the show. It's a real workhorse enzyme, and as we discussed in lecture, you'd be very unlikely to survive without it because of the critical role it plays in the chemical reactions that keep the reactions at the capillary bed and at the alveolus proceeding. So you really, really need those chemical reactions in order to be able to load up your hemoglobin with oxygen and to make the hemoglobin let go of oxygen when it's done. So carbon dioxide and water are combined to form carbonic acid. Oops. Let's erase that. Carbonic acid, there we go. And because carbonic acid is an acid, we know that means it donates protons to solution. So it almost immediately dissociates into this, which is bicarbonate, and this, which is a proton. So the chloride shift happens again, but in this end, we are pumping the bicarbonate out and letting the chloride in. I'll show you that picture in a minute. The proton ends up being destined to bind to hemoglobin. So because protons bind to hemoglobin, that reduces hemoglobin's affinity for oxygen, and the proton takes its place. So the real reaction looks like this. And remember, we have to do accounting on both sides to make sure all things are equal, because that's how chemistry works. So we have HB plus O2. There you go. So now we have freed up O2 that can diffuse into the tissues. So hemoglobin arrives 97% saturated and leaves only 75% saturated. So this is a utilization coefficient of 22%, which just refers to how much oxygen that you loaded at the alveolus is actually being sent to the tissues and how much remains in the venous reserve. And of course, as we discussed previously, that's going to change depending on how metabolically active your tissues are, because, at rest, you're going to be not using as much oxygen, but when you exert yourself, that number will change. So here's a picture of the same thing. You'll note that the picture is pretty much identical. In fact, it's exactly identical, but the orders of the arrows are reversed. So this set of reactions is completely reversible, and it's reversible depending on relative amounts of reactants and products, and more specifically, on different partial pressures. Okay, so let's talk about oxygen versus carbon dioxide transport in the blood. Oxyhemoglobin, which is HbO2, contains 98.5 chemically combined oxygen and hemoglobin, and this exists inside red blood cells. Now I'm highlighting and circling and underlining inside because remember, free hemoglobin causes renal failure. It blocks your kidney tubules and it causes your kidneys to stop working. So hemoglobin is great as long as it's inside of your red blood cells. If it creeps out somehow, then you start to have major health problems. Now remember, oxygen has low solubility in water compared with carbon dioxide, so it doesn't really dissolve very easily in the blood plasma, and that is why we only have about 1.5%. So only the dissolved O2 can diffuse into tissues, and that means that in order to basically get O2 into the tissues, you have to make the hemoglobin let go of it. What that means is that since 98.5% of the oxygen is bound to hemoglobin, factors affecting the dissociation of oxygen from hemoglobin are very important. So, how likely or unlikely hemoglobin is to give up its oxygen in different metabolic conditions is something that sports physiologists and scientists and doctors worry very much about. So the dissociation curve shows levels of saturation and oxygen partial pressures on an XY axis. Carbon dioxide transport, most of it occurs as bicarbonate ions in the plasma as a result of this, again, reversible reaction, and that's in the amount of about 70%. We also have carbaminohemoglobin, which is the name for all of the hemoglobin that is bound to carbon dioxide and all the carbon dioxide that's bound to plasma proteins that aren't hemoglobin. And the remaining 7% is present as dissolved gas because remember, CO2 is more soluble in water than oxygen is by a factor of many. So, what factors might affect oxygen unloading at a respiring tissue? So this is hemoglobin releasing oxygen where it needs to be released, and that's the critical element because ischemic tissues die very quickly. So ambient partial pressure of oxygen and the difference between the partial pressure of oxygen between the tissue and the blood is an important one. So an active tissue is sucking up oxygen because it's burning it for fuel, or rather, more correctly, using oxygen to burn fuels like glucose. And that causes an increase in the gradient between the tissue and the blood and then facilitates increased O2 release. An active tissue also has an increased temperature, which facilitates oxygen release. And the Bohr effect, and this is one of those things that is named after a guy, Niels Bohr. So active tissue have high partial pressures of carbon dioxide. So they're pumping out carbon dioxide as a waste product at a higher rate than average. And that, due to the carbonic anhydrase reaction, is going to raise the numbers of protons present, which is going to lower pH, and turns out hemoglobin is more likely to give up its oxygen if there are protons around, for the same reason that we saw in the slide of the alveolar, no, excuse me, not the alveolar, of the blood tissue interface. There's also a metabolic intermediate inside red blood cells. It's called bisphosphoglycerate, and it's a metabolic intermediate because this is a step in lactic acid fermentation. So remember, no mitochondria, so no oxidative phosphorylation. They can only do lactic acid fermentation, and bisphosphoglycerate is a byproduct of that. So lots of different things can cause BPG increases. So fever can, thyroid hormone, growth hormone, testosterone, and epinephrine all raise BPG and cause oxygen unloading. And they do that by acting on the red blood cells themselves. And carbon dioxide. So an increase in CO2 decreases the affinity of hemoglobin for oxygen. And that is called the Haldane effect. So basically, if you're experiencing increased CO2, hypercapnia, or external CO2 increases, that CO2 is going to end up pulling oxygen off hemoglobin. So, hemoglobin and oxygen partial pressures. So this is the percent saturation of hemoglobin, which is another way of saying how many O2 are bound to HB. So 100 means all of your hemoglobins have all of the possible oxygens on them. So every hemoglobin is actively carrying 4 O2. And 0 means that none of your hemoglobins are carrying any O2. So this is just showing you average respective values of blood at different spots, because of course this is going to be a curve because not all of the blood in your body has the same relative proportions of oxygen and carbon dioxide. So oxygenated blood in systemic arteries comes to about here. So if we trace this down, PO2 is 100, and that means the saturation of hemoglobin is slightly less than 100, so 98%. So it's not a perfect holder of oxygen due to its reversible binding affinity. So blood is almost fully saturated at a PO2 of 60 millimeters of mercury. And you'll notice that after this point, the curve levels off really fast, so there's not much more you can saturate beyond this. So if you drop below the partial pressure of oxygen required, oh, excuse me, I meant to do this. There we go. So after this line, we get a leveling off of the curve. So this means that people are okay at high altitudes and with some disease, because the part of the curve where this relationship is more exponential and less flat is down here. So between 40 and 20 millimeters of mercury, large amounts of O2 are released as needed in areas like contracting muscle. So below this 60 millimeter of mercury point, the amount of O2 released is going to be roughly proportional or a little bit more than proportionally related to how hard the tissues are working. So this is showing you how the curve might shift as a result of changes in blood pH. So normal blood pH should be about 7.4, which is a little bit more than neutral. If your blood pH drops to at or below 7.2%, that's considered acidotic, so acidosis. And remember, the pH scale is logarithmic, so although this doesn't seem like a very significant difference, because it's a factor of 10 on the y-axis for pH scale, that's quite a difference in number of protons. So the percent saturation of hemoglobin, so how many hemoglobins are actually full of oxygen, is going to be less for the same partial pressure of oxygen because there's more protons around, encouraging hemoglobin to give up its oxygen for the given amount of oxygen. The converse is true as well. So if you don't have enough protons around, your hemoglobin has a harder time letting go of its oxygens, so it's going to shift the curve back towards the y-axis, meaning that, let's say at 30 millimeters of mercury, where ordinarily you would have about 45% saturation, now at 30 millimeters of mercury, you have 65%. So that's a 20% difference, which is quite a bit. Carbon monoxide poisoning is a result of carbon monoxide having a higher binding affinity for hemoglobin than O2. So let's write that in there. So for whatever reason, the heme groups in carbon monoxide like to grab onto carbon monoxide more than they do to oxygen. And that has to do with some chemistry stuff that we won't really go into, but enzyme kinetics states that certain compounds are going to bind more or less strongly and more or less reversibly to the active site of a given protein or enzyme. So you treat carbon monoxide poisoning by administering pure O2 in the hopes that it will just swamp out the carbon monoxide and eventually replace all of the spots that have bound carbon monoxide with oxygen instead. You can also do this using a hyperbaric chamber. All right, PCO2 and oxygen release. So this is directly related to the fact that carbon dioxide gets converted by carbonic anhydrase into carbonic acid and eventually protons. So it's similar to the Bohr shift model I showed you before, and in fact the curves look pretty much the same because of this proton action. Temperature also activates this, and I don't know why this Unicode error has turned this little degrees thing into a weird curly Y, but it should say 98.6 degrees, not whatever that is. So low temperature decreases the catch and release time, so it causes hemoglobin to be less likely to give up its oxygen. And higher temperature is either indicative of fever and therefore metabolic activity, or just metabolic activity in general. So maybe you're exercising more and your skeletal muscles are demanding more stuff, or maybe you're shivering, or maybe it's just hot out. So higher temperatures cause more BPG, but also they just cause hemoglobin to tend to let go of oxygen more readily. So it's a combination of both. Now, I mentioned earlier in the lecture that fetal hemoglobin has gamma chains instead of beta chains in its hemoglobin. So one set of its protein chain tetramers is different from adult hemoglobin. And we won't go into exactly how, it doesn't really matter. You just need to know that fetal hemoglobin is different. And it also has a different structure and affinity for oxygen. And that's because fetal oxygenation needs are a little bit different than in neonates or than in adults. First of all, a fetus doesn't have to oxygenate its own blood. And second of all, fetuses tend to use oxygen differently as they grow and develop because they don't start out fully formed, of course. What this means is that when the partial pressure of oxygen is low, which ordinarily would mean that you couldn't carry as much oxygen, for fetal hemoglobin, they can carry more O2 than adult blood. So if you look at the fetal versus maternal oxygen and hemoglobin saturation curves, you'll notice that for the same PO2, let's say just for ease, 40. So I'm going to draw a line up to 40 here. Okay, so at 40 millimeters of mercury, partial pressure, maternal blood is going to be able to carry 75% saturation. At the same PO2, fetal hemoglobin can carry just north of 80. So let's call that 82. Oops. And that's quite a difference. So what that should tell you is that fetal hemoglobin is pretty different from maternal hemoglobin. And the reason for that is that maternal blood, by the time it gets to the placenta, has less O2. So this change in fetal hemoglobin allows the fetal hemoglobin to basically grab more oxygen even though the partial pressure is low. So it facilitates oxygen uptake by the fetus. Okay, adjustment of tissues to metabolic needs of tissues. So let's say you're working out really hard. You're contracting and relaxing your skeletal muscles, maybe a lot of times in a row. So you're kickboxing or doing Zumba or taking a spin class or something that's really, really working your skeletal muscles hard. CO2 loading into the blood is going to need to increase, and CO2 scrubbing from the blood into the atmosphere is also going to need to increase to prevent protons from building up in your bloodstream. So the Haldane effect, here's another guy, states that a low level of oxyhemoglobin, for example, in an active tissue, enables the blood to transport more carbon dioxide in total. And that facilitates you getting rid of that carbon dioxide so that you don't become acidotic during exercise. So oxyhemoglobin doesn't bind CO2 as well as deoxyhemoglobin. So this one, remember, they're binding not at the heme group but at the side chains. This one likes CO2 more than oxyhemoglobin. And that's going to shift the reaction to the right, because remember, reaction kinetics are determined by the relative amount of reactants, which are on this side, and products. So if you have an increase in CO2, you're going to have more CO2 available to combine with water to do this stuff. Okay, so that's all what happens when your body is working like it's supposed to. But what happens if there are oxygen problems? Well, it turns out not all oxygen problems are created equal. So a lack of oxygenation can come from a variety of forms. So we'll go through those in this particular slide. So hypoxemic hypoxia seems really redundant. It's usually due to inadequate pulmonary gas exchange. So this means that you're experiencing hypoxemia due to the fact that the air you're taking in is either not oxygenated enough or you're just not getting air. So it's typically pulmonarily related rather than inadequate circulation. So high altitudes can cause this, so can drowning, aspiration of fluids primarily, but really anything. So it's usually fluids, like you are eating while drinking and you get water down the wrong tube. Respiratory arrest for whatever reason, degenerative lung diseases that cause loss of lung tissue, or carbon monoxide poisoning, the significance of which we've previously discussed. So ischemic hypoxia is hypoxia not due to the fact that your blood isn't carrying enough oxygen, but rather the blood just isn't getting where it needs to go. So inadequate circulation is going to cause this. And if it's prolonged enough, it can cause loss of extremities. So if you get ischemic hypoxia that is prolonged enough in your hands or feet, that can eventually cause the loss of that limb. Anemic hypoxia is a result of anemia, either, remember from blood, either not enough red blood cells or not enough hemoglobin in those red blood cells. So typically the second one, not enough hemoglobin, is a result of vitamin B12 deficiency. That's called pernicious anemia. So you have plenty of red blood cells, they just don't have that much hemoglobin inside of them. Histotoxic hypoxia refers to hypoxia that's secondary to a metabolic poison. So anything that interrupts the ability of your body to use oxygen is going to cause this process. So metabolic poisons like cyanide do this. And cyanide basically prevents the cells in your body from using oxygen to burn fuel. So we call it cyanide because it causes cyanosis, which is blueness of the skin. And the primary effect of hypoxia is tissue necrosis, so this is death of tissues that's not supposed to happen, and organs as well, with very high metabolic demands affected first. All right, oxygen excess. So turns out too much oxygen is also bad. So oxygen toxicity happens when you have pure oxygen, and this actually should say O2, breathed at 2.5 atmospheres or greater. So you need two things. You need a bunch of oxygen, so not a gas mixture, but just pure oxygen, and you need to have that be pressurized. So this generates free radicals and hydrogen peroxide, so that's what this is. And free radicals, so like superoxide free radical, which is O2 radical sign minus. So remember, free radicals like to run around and rip electrons off of anything they can find, really. But if it happens to be these organelles of your tissue, that can cause damage. So it can destroy enzymes that you need to survive. It can damage nervous tissue and even cause seizures and death. So there's a direct link between oxygen toxicity and free radicals, and that's what ends up doing the deed. Hyperbaric oxygen is formerly used to treat premature infants. So this is basically this. So pure O2 at high pressure. And this caused retinal damage, so specifically rods and cones damage, and that was therefore discontinued. So sometimes something that seems like a good idea is actually not a good idea. Okay, so for the last couple slides, let's talk about disease. So COPD, or chronic obstructive pulmonary diseases, so these are diseases that prevent you from taking in air. So they're not related to a loss of lung compliance directly, but rather a blockage of your airways. Asthma is usually acute and transient. So an asthma attack is where an allergen of some kind triggers histamine release, and that results in intense bronchoconstriction. So it's acute, meaning it usually doesn't last very long as it's treated, and it's transient, meaning it's not present all the time, it comes in attacks. Other COPDs, usually associated with smoking. So smoking cigarettes damages your airway, and in excess it can give you chronic bronchitis. So bronchitis means inflammation of your bronchioles. And this has a number of outcomes. So it seems like it would just cause your bronchioles to be puffy and swollen, but it does a bunch of other stuff too. So one thing it does is causes the cilia to be damaged to the extent that they're immobilized. So now you can't use your mucociliary escalator. Oops. And that's, of course, going to result in a buildup of mucus in your lungs. They also decrease in number, which is also bad. The goblet cells, to try and compensate, enlarge and produce excess mucus, and that ends up forming sputum, which is a gross word because it's a gross substance. So sputum is a mixture of mucus and cellular debris from dead cells that you killed by smoking. Oops. I don't know why it keeps doing that. There we go. So this is an ideal growth medium for bacteria because it has lots of delicious cell pieces in it that they can use to metabolize, and that results in chronic infection and bronchial inflammation. Emphysema is a loss of alveolar tissue, so you end up having fewer alveoli in total, which really, really cuts down on that huge amount of surface area. So that's step one. You get alveolar wall breakdown, so what that ends up meaning is fewer alveoli. Dang it. Also, a grammar note here. If the thing that comes after this is plural, you never say less alveoli. You always say fewer. It's a grammar mistake I hear made all the time, and it's a pet peeve of mine, so I'm here to tell you fewer alveoli, not less alveoli. Fewer cows, not less cows. Less cows sounds like you're accusing somebody of not being maximally cow, which is silly. All right, I'm hopping off my soapbox. Back to anatomy. So the result is you get much less respiratory membrane, so less surface area for gas exchange, which means that you're simply incapable of taking up as much oxygen. That's bad. Secondary to that, so this is a secondary or chronic complication, is that in response to constant damage, your lungs attempt to repair the damage with scar tissue. And remember, scar tissue is primarily collagen. And collagen is not as elastic as alveoli. So you get a loss in compliance that is secondary to an obstruction. So air passages collapse and obstruct airflow, and you get air trapped in the lungs. So it's also harder to exhale for these individuals. And there's a waiting to exhale joke in there somewhere, but I don't feel like making it right now. So you can just mentally imagine that. Other effects of COPD, you get a decrease in pulmonary compliance, so lungs are less stretchy. and vital capacity, which remember is basically a measurement of the stretchiness of your lung. So how much total air are you able to move? That goes down. That results in hypoxemia, hypercapnia. So why both? Well, you can't get enough air because you don't have as many alveoli, and you get hypercapnia because it takes you so long to exhale. It's like exhaling through a straw. And the ultimate result is respiratory acidosis. Hypoxemia stimulates erythropoietin, and that's a constant hypoxemia, so you get constant EPO release, which leads to secondary polycythemia. So remember, polycythemia is too many red blood cells. And that ends up making your heart work harder. It can cause your blood to be sludgy. And the outcome of secondary polycythemia is this, cor pulmonale. So you get hypertrophy and potential failure of the right side of the heart, and that's due to the obstruction of pulmonary circulation in particular. So remember, right-sided heart failure and left-sided heart failure are different. Also regarding smokers, they have a lowered respiratory efficiency, so their ability to perform gas exchange and move gas around by ventilation is reduced. So nicotine as a chemical binds to nicotinic acetylcholine receptors in the terminal bronchioles. So remember, acetylcholine is associated with muscular contraction, and it's true in the smooth muscle as well as the skeletal muscle, so nicotine ends up constricting terminal bronchioles, making it harder to move air through them. There's also carbon monoxide in cigarette smoke that binds to hemoglobin, so you get hypoxia due to low levels of carbon monoxide. Irritants in smoke also cause excess mucus secretion, so things like tar. And they also inhibit movements of the cilia. So because tar, if you've ever seen tar, it's sticky. It prevents movement of things. And in time, this destroys elastic fibers in the lung, so that results in reduced compliance and trapping of air in alveoli. So if you can't move air out of your alveoli as fast as you're moving it in, that air is going to go to equilibrium from a gas exchange perspective, and then you can't get any more oxygen out of it. So that results in a net reduction in gas exchange. So it might seem like trapping air in your alveoli is good, but it's really not. Lung cancer also accounts for more deaths than any other form of cancer. So yes, there are other forms of cancers that vary in proportion, specifically in the United States. But it turns out smoking is kind of the big cause of lung cancers. And that's because smoking causes 15 carcinogens, although there are some lung cancers that are genetic, so you can just be genetically predisposed to them. Squamous cell carcinoma is type 1 alveolar cells. And they basically take over. So it seems like it would affect them, but instead of that happening, it starts by transformation of bronchial epithelium, which should be pseudostratified ciliated columnar epithelium, into stratified squamous instead. And those dividing cells then invade the bronchial wall, causing bleeding lesions. Eventually, scar tissue takes over, and you get dense swirls of keratin and eventually collagen replacing functional respiratory tissue. So instead of having type 1 alveolar cell simple squamous, you've got this rogue stratified squamous that is too thick for gas exchange and takes over your lungs. Adenocarcinoma originates in the mucus glands that line the lamina propria of the bronchi. And small cell, also sometimes called oat cell carcinoma because of their appearance, this is the least common, but it's the most dangerous. So this originates in the primary bronchi and invades the mediastinum and kind of spreads around the mediastinum, so it metastasizes quickly. And remember, metastasis is movement of a tumor from one initial location to another. So travels. So it can travel to heart, to breast tissue, And really, if it gets into the blood, anywhere else it likes. So that's why it's so dangerous, because it tends to break off and enter your bloodstream. So with regard to the progression of lung cancer, 90% of lung tumors originate in the primary bronchi. So remember, these are also called your main bronchi. And the tumor begins to encroach on the bronchial wall and compress the airway, which may cause interruptions in breathing, which are, and this is a hard word to say, atelectastasis. Often the first sign is coughing up blood because the tumor invading the wall causes bleeding ulcers, which then irritate the inside of your bronchus and carina and cause you to cough. That's a coughing reflex. So metastasis is rapid and usually has already occurred by the time of diagnosis. So this is kind of the deal where by the time you notice it, it's too late. So common sites of metastasis are pericardium, heart, bones, liver, lymph nodes, including breast tissue, because there are lots of lymph nodes in the breast tissue, and brain. So basically anything that's kind of nearby. And the prognosis for this is poor. So 7% of patients survive 5 years after diagnosis. There are rare cases where people go into remission and remain that way, but because this is a cancer that's primarily linked to habit rather than a cancer of accident, it can be really hard to get these people to stop smoking and stay quit, so it tends to recur. So let's compare healthy lungs to a smoker's lung, specifically one with carcinoma. So notice, due to daily exposure to particulates, a healthy lung isn't necessarily perfectly pink and clean. So we've got these little buildup areas here. And those are just due to daily exposure to impure air. So urban living equals buildup of gunk. And you're going to have this unless you were raised in a bucolic environment with nothing but the purest alpine air. So you'll see, oops, go away. You'll see in the lung tissue from the human lung that we had in lab, the plastinated one, it looks very like this one where there's a bunch of little specks in it. That's not because the person necessarily was a chronic smoker, but more likely just due to them living somewhere where there's airborne pollutants. This mess is a smoker's lung. So you can see bleeding all over the place and buildup of black tar and then carcinomic tissue. So it shouldn't look like this. This is dense yellow scar tissue and cancerous tissue. Here are some other disorders of the respiratory system, and I'm not going to read you this because I assume that you can read. So rhinitis is just the common cold. So rhine means nose. Rhinitis means your nose is inflamed. So that's a disorder of the respiratory system because it affects your upper respiratory tract. Adult respiratory distress syndrome is acute lung inflammation and alveolar injury stemming from trauma. And it can be caused by a lot of things. Drunk people often get this due to aspiration of their own vomit, specifically if they vomit in their sleep after passing out. So that's another risk of alcoholism. Same deal with drug overdoses. Pneumonia is a lower respiratory infection, can be caused by a lot of things. So people tend to lump pneumonia into one category. It's usually Streptococcus pneumoniae, which is where it gets its name, but it can be caused by viruses, fungi, or protozoans. Sleep apnea is when you stop breathing for 10 seconds or longer during sleep. And if it occurs often, so hundreds of times per night, that's going to produce chronic hypoxia, lots of snoring, usually restlessness, so poor sleep quality. And tuberculosis is an infection with the bacterium Mycobacterium tuberculosis. So this is a sporulating bacteria, spore forming. And it basically builds up nodules called tubercles around the bacteria, which is your lung's way of trying to wall off the infection. But that reduces pulmonary compliance and is pretty damaging. And that is the end of that. So the next screencast will be me starting the urinary system, which we will presumably also start to do on Wednesday in class. So thank you for your attention, and I will see you next time.